Good morning, everyone. Today, I'll be presenting a journal club under the guidance of my moderator, Dr. Mohan Dhyani, sir. The title for the journal club is Depressive Symptoms and Psychological Distress from Antenatal to Postnatal Period in Women with High-Risk Pregnancy, a prospective study during the COVID-19 pandemics. This journal of psychiatry is from Indian Journal of Psychiatry, volume 63, issue 6, this published in December 2021. Indian Journal of Psychiatry has a formal name of Indian Journal of Neurology and Psychiatry. It was edited by Professor Om Prakash Singh. Publication history, it started in 1949 and is published till currently. The present publishers are Medknown Publications on behalf of Indian Psychiatric Society. The publications are done quarterly and the impact factor for the journal is 0.81, that is 81%. Coming to the background of the article, the impact of coronavirus disease 2019 pandemic on mental disorders in postnatal period remains unknown. So the article tells us about something about the antenatal and postnatal stress in the COVID-19. In January 2020, the WHO declared the outbreak of coronavirus disease a public health emergency of international concern. During the incidence of traumatic events, people are more likely to experience negative emotions. It has also been found that women are more likely to show the signs of stress, anxiety, and depression. Prenatal and postnatal periods are vulnerable times that may increase the frequency of psychiatric disorders. Childbirth may be accompanied by stressful experiences where some women may have post-traumatic stress disorder in postpartum period following a stressful labor experiences. In women with psychiatric disorders, the risk of poor pregnancy outcome increases, such as preterm birth, pregnancy loss, and intrauterine growth restrictions. In the first month of 2020, pregnant and breastfeeding women who face the COVID-19 pandemic suffer from an additional stress that included fear of infection, unprecedented quarantine, and the fear of going to hospitals or clinics to receive medical consultation. These additional problems might have negatively impacted emotional well-being of women and disturbed their personal and professional life. This study had three aims: to assess the depressive symptoms and psychological distress in antenatal period in women with high-risk pregnancy before COVID-19, to investigate the depressive symptoms and psychological distress in antenatal period in women with high-risk pregnancy after COVID-19, and to estimate the post-traumatic stress disorder prevalence during the COVID-19 pandemic in postpartum period. What are the materials and methods, and who are the participants? It is a type of prospective study conducted at a referral perinatal care center from December 2019 to June 2020. The study was approved by Ethics Committee of the Institute. Written informed consent was obtained from all the participants before the study, and the study had two phases: prenatal screenings and postnatal follow-ups. The inclusion criteria included the women who were diagnosed with high-risk pregnancy. Their age was older than 18 years and had an education level of at least primary school. The sample size was estimated to be 122 concerning the pilot information before the start of the study. There were three hypotheses. First hypothesis says that there is no relationship between the psychological distress in antenatal and postnatal periods. However, the null hypothesis says that there is a significant positive relationship between the psychological distress in antenatal and postnatal period. The second hypothesis was that there is no effect of pregnant women's exposure to COVID-19 on the prevalence of depressive symptoms in postnatal period. And the null hypothesis was that the pregnant women exposure to COVID-19 increases the prevalence of depressive symptoms in postnatal period. And lastly, the third hypothesis was that there is no effect of pregnant women exposure to COVID-19 on the prevalence of PTSD in postnatal period. And the null hypothesis was that the pregnant women's exposure to COVID-19 increases the prevalence of PTSD in postnatal period. What are the tools used in the study? The study used the three scales. First is Edinburgh Postnatal Depression Scale, that is EPDS. Then is Brief Symptom Inventory, that is 53 item checklist. And scales were filled twice during antenatal and then postpartum period, that is 2 to 6 weeks after the delivery. And then there was one test used to assess the PTSD also, which we'll be studying further. As the COVID-19 pandemic started in March 2020, many of the women were not admitted to the obstetric clinics to the hospital to receive postpartum care. Thus, they had to contact them through online surveys. During 2 to 6 weeks of postpartum period, the researchers had to call the participants and invite them to complete the survey for filling the skills. The researcher conducted this phase using the DigiSurvey platform through a link sent to the women using WhatsApp or Telegram. Researchers sent 3 scales including EDPS, BSI 53 and primary care PTSD screen to all the participants of phase 1 through a link. Only 41 participants filled the scale in the follow-up. Women with a score of EPDS score of more than 10 or PTSD score of more than 3 were to consult a psychiatric resident to a hospital to conduct a structured clinical interview for DSM-5 to diagnose their mental disorders. Women who were diagnosed with mental disorders were given an appointment with a psychiatrist to receive an appropriate treatment. And women who were diagnosed with mild to moderate mental disorders, for example, mild to moderate depressive disorders, received online cognitive behavior therapy. Also, pregnant women diagnosed with severe mental disorders, for example, severe depressive disorders or post-traumatic stress disorders, received appropriate pharmacotherapy plus online cognitive behavior therapy. The tools used were, first was the primary care post-traumatic stress disorder screen. This scale was used to see the PTSD in the patients. The scale consisted of 5 items and each item had dichotomous answers in yes or no with a score between 0 to 5. A cutoff for more than 3 or more than 3 had a maximum sensitivity to PTSD diagnosis. The second is Edinburgh Postnatal Depression Scale. It is used to assess prenatal and postnatal depression. It consists of 10 items with a 4-point Likert type scale ranging from 0 to 3. The total score ranges between 0 and 30. The higher the score, the greater the symptoms. In EDPS, we use a cutoff of score of 13 or higher for the detection of depressive symptoms. The third one was the Brief Symptom Inventory 53 item checklist. It had 9 psychiatric symptoms including depression, anxiety, interpersonal sensitivity, somatization, obsessions, compulsions, phobic anxiety, hostility, paranoid ideations, and psychoticism. Also, we measured global severity index to assess the psychological distress in pregnant women. Global sensitivity index was calculated by dividing the sum of score of all the questions by the number of questions. And psychological distress was defined as the T score for CGI of 63 or greater in brief symptom inventory 53 item checklist. The statistical analysis, a chi-square test was used to investigate the change in frequency of depressive symptoms and psychological distress between antenatal and postnatal periods. A paired t-test was employed to compare the mean score of depressive symptoms and psychological distress in antenatal and postnatal periods. Statistical significance was set at a p-value of less than 0.05, and the statistical analysis was performed using SPSS version 24 software. The results in table 1, that is the demographics of the pregnant women during the phase 1 and phase 2 of the study. About 1/3 of women, that is 41 out of 122 participated in phase 2. And the most of the women in phase 2 of the study had an educational level of high school. This is the table 1, which shows the various demographic profiles of the participants and the two phases, that is antenatal phase and postnatal phase. Then of the 122 women with high risk pregnancy assessed in antenatal period, 23 women had a total EPDS score of more than 13. Of the 41 pregnant women followed up at 2 to 6 months of postpartum period, 34 had an EPDS score of above 13. Further, 6 of the 7 pregnant women with antenatal depression, with a total sample of 41, continued to have depression at postnatal assessment, indicating 85.7% persistence of depressive symptoms from antenatal to postnatal period. Of the 41 women assessed in postnatal period, 35 had depressive symptoms, of whom 28 did not have antenatal depression. So these 35 were those who developed depression after delivery, that is postpartum depression. Thus, the prevalence of postnatal depressive symptoms is estimated to be 80% during the first acute phase of COVID-19 pandemic. And none of the 41 women who completed the scales in postnatal period were infected with COVID-19. Then the table 2 indicates the frequency of depressive symptoms and psychological distress in antenatal and postnatal periods. So with the total N of 41, 7 women had antenatal depression, followed by 34 which continued to be in postnatal periods. Psychological distress was seen in 13 females in antenatal period and in which continued in postnatal as 24. And the p-value for both was less than 0.01. The frequency of depressive symptoms increased significantly by about 5 times from antenatal to postnatal period. In addition, the frequency of psychological distress increased significantly by about 2 times from the antenatal to postnatal periods. Also, there was a strong positive correlation between the global severity index and the postnatal GSI seen in table 3 and 4. The results confirmed that the depression score of women with complicated pregnancies increased significantly from antenatal to postnatal periods. And also, the psychological distress increased significantly in the pregnant women from antenatal to postnatal periods. This is the table 3, which shows the increase in symptoms from the antenatal to postnatal periods of depression. And this is the table showing the psychological distress, that is the increase in psychological distress from antenatal to postnatal periods. Discussions. The finding revealed that 12.2% of the pregnant women experienced PTSD symptoms in postpartum period during the pandemic. The study found that both the onset of postnatal depression and the persistence of antenatal depression were high in women with high-risk pregnancies followed up in COVID-19. The frequency of depressive symptoms among the women with high risk increased significantly by about 5 times in postpartum period compared to antenatal period. There were certain limitations of the study that women with high risk pregnancies experience more serious psychological problems than those with a low risk group. So the participant in this study were the women with high risk pregnancy, so there was little biasness. In the acute phase of pandemic, clinic appointments were limited in the public maternity settings only. The number of participants was very small in postnatal period, and there was a loss of about 80 pregnant women in the prospective phase, which was the main limitation of the study. And the change of assessment methods of outcomes from filling in the questionnaires at the clinic to conducting an online survey has also affected the results. The conclusions was that the study demonstrated that COVID-19 might have aggravated the prevalence and persistence of postnatal depression in women with high-risk pregnancy, and the potential long-term negative consequences of this crisis should be addressed in the future. There was no financial support and sponsorship for this study. Thank you, sir.
So, any questions, comments? Journal club is very important because it helps us to think critically and critically evaluating the literature, the publications which we do. So, any questions, comments? I think Dr. Mantaz and Dr. Priya, you have to contribute. So one important thing for exam going is Indian Journal of Psychiatry. First publication was 1949, and
Yes.
the current editor is Dr. O.P. Singh. This is must to remember. An impact factor of the journal is 0.81.
Yes.
So we never say impact factor as 81%. Okay. So,
Yes,
but
sir.
what do you mean by impact factor, Dr. Akriti?
The impact factor is the how much acceptance of the journal or
so please read and what is an impact factor. Okay, and there are the various agencies giving various impact factors, which is the most commonly type of impact factor which is accepted. Regarding the study which you have presented, can you tell us why there was so much of dropout?
So the pandemics, the COVID-19 pandemic led to the dropouts.
So, but did they do the assessment on only on those females which caught COVID-19?
No, sir. Those who developed COVID-19 were not included in the study. And so there was a difficulty in the survey, like online surveys were not possible for everybody. Like there were females who did not have the online access. So, so that was
COVID-19, the patients which the women which got COVID-19 were excluded from the study.
Yes, sir. The article says that the 41 females who participated did not get infected with the COVID-19.
Okay. Okay. And any other limitation which you can point out? Any methodological flaws which are there?
So the subjective scores, the scales are subjective. And so there was a
Okay.
difference in scoring when when the scoring was done in the clinics and then when the scoring was done in the online basis.
Mm-hmm. Online, how did they score? By telephone interviews or how they have scored?
So WhatsApps and the Telegram platforms were used.
So there can be a difference, right?
Yes, sir.
Okay. Okay. Any other questions? What kind of a study is this then? What is the what is this? What is a model of the study?
So it's
Which
a prospective cohort study.
yes, very good. So this is a cohort study. You know, they
Yes, sir.
selected few high risk
Right.
pregnancy candidates and then they followed it up subsequently, and and then they assessed all these measurements. So PTSD, why they applied PTSD? What
So,
kind of a trauma was there?
so like pregnancies in itself are stress and itself a stress for the females, and the COVID-19 pandemic added to the stress like fear of acquiring infection, going to the hospitals, fear of what will happen to the children if the children might get infected. So that, and the pregnancy, the females were already high risk. So their need for going to the hospitals were more than the females with low risk. So that led to the inclusion of PTSD in PTSD scale in the study.
Mhm. Don't you feel that because it's a shadow trauma kind of a thing or vicarious trauma, so this could be a limitation?
Uh,
And they included the conducted the second phase from Feb to June. They
yes, sir.
themselves are saying he started in March, and I'm sure that in March the number of cases would be very less. Maybe by June it would have spread. So in initial phase of the illness, the symptoms would be little different from the later phase of the illness when we consider phase two, because that is how they have compared it. So in
Uh,
that sense, it can be a limitation. So you have to think critically. Okay.
yes, sir.
And that is very subtle point. If February, maybe the cases which were evaluated in February, तब तो कोविड आया ही नहीं था. मार्च में थोड़ा सा आया था, अप्रैल मई जून वो बढ़ता गया. So cases
Yes.
which were evaluated early may had a less of these symptoms than that. Any other
So,
any other?
so the first interview was done in the Feb time. That was
Mhm.
antenatal period, and then the postpartum interview that which had to be taken was in the after the like during the wave. So
But they said na, they have said here that second phase was conducted to assess the changes of psychiatric disorders of the participants in postpartum period from Feb to June 2020. That is what they have written.
yes, sir.
So they have given that kind of a timeline here.
Yes,
Any other
Dr. Akriti,
yes, sir.
why they were choosing education qualification above primary school participants?
For the understanding, so for the like understanding of these scales and what we are doing.
Have you seen whether any particular studies had done previously?
So in this, like in this topic, sir.
No, no. Is there any? Actually, they have mentioned references like above primary school chosen by previous studies.
No, sir.
I think an important limitation also is this PTSD, because 2 months PTSD we measure generally after a month of the contact with the trauma.
Yes.
So the trauma, maybe if you see that March it came, So ultimately, from April only, they could have assessed PTSD. So because then within a month, we don't call it PTSD. It is post-traumatic. So that can be an important limitation. So you have to think like this journal has come to you for review. You want to tease out faults. One thing is presenting, and one thing is also teasing out faults. So these are very two simple things which you can point out, and on basis of these two simple points, we can reject this journal, reject this paper. Anyways, any other questions? So I feel that Dr. Akriti has done a very good job. This is a cohort studies are little difficult to present, and she has picked up the study vividly. Maybe also we can add some timelines to make things more coherent. Any other comments by, I think, Srinivasan, your comment?
Akriti, you have done very good job. Actually, last 1 month back, you have chosen this paper, but by presentation wise, you have done. You have mentioned like a simple content and understandable. Thank you, Dr. Akriti.
I think Dr. Amrit is also there. Sir is a very senior psychiatrist of Morisa. I'm happy that Sir has joined this. Sir has attended this presentation. Sir, any comments from your side? Or this is Dr. Meena? Okay, so we end up this presentation. Then we subsequently thank you to Dr. Akriti for a good presentation. You can share your slides with the on the departmental mail. Thank you.
Thank you, sir.
पेशेंट का एटीट्यूड तो देखा है